I'm an orthopedic surgeon who had been in this field since 1990. So it's almost now 36 years we've been actively working. And there is where we found that there is some problems which are very difficult to treat. And that is what we tried to innovate so that something may stay back in these persons who get fragility fractures. So if you look into the typical construct which are available today, when we do an internal fixation by plating, the three things on which a typical construct relies is bone, plate, and screw.
Okay, welcome back, folks. Today in our podcast series in the Brew with Bones, we have this distinguished professor with us launching our episode on Indian innovators. So we have with us Dr. Professor Sandeep Srivastava. So he's an executive director, he's a scientific officer, he's a surgeon, he's a scientist, and he has lots of accolades under his name, which just goes beyond the length and breadth of his profile. So we now are going to discuss in this podcast series about inventions and the inventors' take on their inventions and how it is going to change the field of orthopedics and so. So we have Sandeep Srivastava sir with us, and we are going to discuss his recent innovation, which is going to make a milestone in the orthopedic implant history. So welcome so much, sir, to our podcast series.
Thank you so much, Satish, and thank you so much, Giri, for inviting me towards Brewing with the Bones series. It's a great privilege to be with you all today.
So thank you, sir. Thank you so much. So we are all ears to hear about your innovation that has been done and that has got lots of awards in various international and Indian conferences. So we are all ears to hear it from you, sir.
So thank you so much, Satish, and thank you so much, Dr. Giri, as well. As I said, it's a great pleasure to reconnect with you young guys time and again. And it's my great honor to do something for humankind, putting our scientific knowledge, whatever we have gained throughout our experiences. I'm an orthopedic surgeon who had been in this field since 1990. So it's almost now 36 years we've been actively working. And when we had been working along, we have seen a lot of things which have gone, which has been forward working because of the things which have got innovated in the um, arena of not only orthopedics but the whole science over here. So from those days when we were trained to look with the proper conservative treatments, to these days when we say we have to specifically let the conservative be for some definite indications and more generalized surgical interventions. There is a huge change. But then, as we all know, there are a lot of difficulties when we think of surgery as a permanent solution, particularly when there is a geriatric population engaged. And there is where we found that there is some problems which are very difficult to treat, and that is what we tried to innovate so that something may stay back in these persons who get fragility fractures. And as you know, Satish, fragility fractures are not so uncommon, and we tend to see a lot of them around us.
Yes.
Fragility fractures are a hidden epidemic. We know this, and we call it as a silent osteoporosis as a silent killer, really. And with those osteoporosis, as you know, the bone mass is reduced in general, and there is a micro-architectural deterioration as a whole. And I was surprised. I was reading some statistics about osteoporotic fractures, and it was so surprising that the literature says, PMC literature, which says that there is a fragility fracture occurring every 3 seconds in the world. So, like, it's 37 million people who are suffering from these fractures. So, 70 fractures every minute. And many of them, most commonly, they are females, and 1 in 3 and 1 in 5 is male. So, and we have read the textbooks Robo Jones, which said, we arrive through the pelvis and go from the neck. And the reason is osteoporosis. So it is associated with huge morbidity, and not almost nearly those persons who suffer fragility fractures, 25, nearly 20 to 25% of them, they end up in dying in first year itself. So it's associated with not only morbidity, but huge mortality also. And the issue is about the fixation of these fractures. Definitely there is a medical treatments available now, much better what it was available before. But then, despite our understanding about stabilities and the construct which you put in as internal fixation, particularly plating, etc., uh, many a times they tend to fail, in particularly osteoporosis. So that what triggered our mind that can we have something more, particularly related to this innovation which we are talking today, that what can be done more to overcome this problem. And this is where I find myself a chance to work up. And over last few years, we took up these issues, try to work up a solution and test those solutions. I'm so happy that finally I got a patent after waiting for 3, 4 years, and now I will be allowed to put it in the humans.
Wonderful, sir. The statistics is really staring at us, and it is very timely intervention that you have innovated right now because, as you said, osteoporosis is a real killer, and it is affecting a lot of our not only geriatric, and it is also in the upcoming, because our population is now getting aged, and us being the most populous country, we need to address this timely so that we have a good hold on managing all these fractures. So, can
Yes,
we have a presentation about your innovation, sir? We can take
surely.
it.
I would love to give a deeper insight into what we have developed and how we are looking it as a good solution to overcome the problems which we have today. So allow me to share my screen. So what we are looking today and we are discussing the innovation is what I have termed as a screw thread interlocking plating system. So in short, I call it as a STIP. So that is one system which we have developed to overcome the problem of fragility fracture fixations. It's an interesting concept. We all know the osteoporosis is a huge problem as we are discussing. And susceptibility to fracture is so much so that at times the patient, they turn around the beds and they sustain fractures. And not only primary osteoporosis, but as well as secondary osteoporosis because of certain diseases which are congenital, lack of calcium, vitamin D deficiencies, and as well as metabolic disorders, lot of metabolic disorders, and including some after tumor-like situations. So osteoporosis is not so uncommon, but there is a problem of fixation always. And this problem leads to loosening of implants, particularly screws, and then leading to fracture failures. Now, current systems, if we look into Satish, they rely
Uh,
on
Once again,
augmenting.
sir, can we minimize that dialog box on the screen because it is obscuring half of the window? The Google Meet thing. Yes,
Yeah,
thank you.
yeah, I can. Is it okay now?
Yeah, now it's fine, sir. Now it's fine.
Okay. So currently, the systems rely more on augmenting the bone screw constructs. I will go a little bit back, slightly back, so that we know uh, what happens when we try to do internal fixation with the help of plates, right? So if you look into the typical construct which are available today, when we do an internal fixation by plating, the three things on which a typical construct relies is bone, plate, and screw, right? So out of this, for the first stability is to bone-to-bone construct. That is when we do an orthopical reductions and we put both the fragments in contact with each other. Second is when you put up a plate to the bone. So the plate remaining to the next to the bone is an important construct, and a lot of designing have improved to see that they remain biologically, they remain anatomically, and they do not cause harm, but they cause what we want, a good compression across the fracture site. So from simple platings to dynamic compression platings to locking dynamic compression platings, etc., are available now. And third construct is screw to bone. Now this is where the fragility fractures have got a issue because the screw to bone construct is very difficult to augment. And things which can be used today and which are being used today is mostly cement. So we put cement and then put up a screw, but that's not a very good way of fixation. We all know. If particularly if you want to remove it, it's a very different thing. Another very good improvement in last few years happened is screw to plate contacts. So screw to plate contacts have been improved by making it a interlocking threads in this plate. So you have a screws which lock in the plate and they should not come out of the plate easily. But then what happens in fragility? When there is a unloaded conditions, the whole construct tends to get up, lift off, as you call it, particularly when the lot of bending load. And this bending load tends to strain the bone-to-bone construct, fracture sites, leading to fracture failures as well after implant failures. So overall, bending loads, leading to catastrophic failures. And finally, even axial loading leads to losing of screws because of micro motion, which keeps on happening at the screw bone interface. So these are the key biomechanical constraints which we face, which are more augmented or rather enhanced when the bone is not of good quality, and that is osteoporotic bone. So arising out of all this study which we have done or we have understood through literature and deep studies, we tend to go with a purpose that how is it possible that we can improve these things. Now, these are the common outcomes so many times. So you have a small cancellous bone, which is fractured at a lower, for example, lower end of femur, even normally in a not so bad osteoporotic bones, and you have a long shaft metaphyseal areas. Now, there are two contrasting bones. One is a cortical bone, and other is a cancellous bone, and fixing the same number of screws as is expected in the cancellous bone is a very difficult task. And the bone tends to break or the screw tends to loosen so many times, leading to fracture failures. So the whole aim of our innovation was, can I increase the grip of the screws inside the bone substance? So can I do something so that the screw remains in its place? Because screw will remain in its place where we are intending to put inside the bone. The bone screw interface will not, bone plate interface will not get loaded up. Once that does not happen, then probably the fracture failures will not happen. So we went into this and we developed a new concept. The fifth pillar, as I call it, the screw to screw construct inside the bone. So you have a bone to bone construct, plate to bone construct, bone to screw construct, and screw to bone construct till now. Going further, we have screw to screw construct, and this is what the innovation is. And the innovation is done through screw thread interlocking plating systems. So that is very interesting concept, right? It's a fifth pillar of stability which we are talking of. So what we are talking of is basically this is a bone, osteoporotic or whatever otherwise, and suppose a fracture has happened. So I put up a anchor screw as I call it. So I am trying to make a bone substance out of steel with a screw only, both sides. And then I am putting up a plate, and then we are putting up screws which interlock inside the bone with another screw. That's a screw to screw construct. And this screw to screw construct, it's very difficult to become loose because of so many things, as you can see evidently over here in the concept, that the primary screw, we have created sort of a stainless steel hole inside the bone, a metal hole, and which is beneath the bone. So there is very less chance that it will come out till the till the plate gets loosened, right? So you can see these heads are buried and beneath the bone, beneath the plate, sorry. So they will not come out so easily. They cannot loosen it. And then when you're putting up the another screws, which I call it thread interlocking screws, they are locking with the threads over these screws. So one surface of them is locked with the main screw, anchor screw, another one is with the bone. So these three screws are making a very strong fifth pillar construct. And of course, these are again threaded to the interlock with the plate. So now this to become loose in fragility fractures is minimized. The risk of whole construct individually getting broken down gets minimized. As a whole, it may still because of so many other reasons, particularly if it is put to excess violence or trauma. That's a different thing. But as a whole, it is minimized. So this is the basic concept, fifth pillar, which I have built on. And so these are the thread locking screws, anchor screws, right? So the whole plating system, as I called is basically Sandeep's thread interlocking plating systems. And the purpose is this acts as an anchoring implant that substitute for the bone substance inside cancellous bones or weak bones. It primarily provides the deep screw threads into which the other two screws can be locked. It is placed under the plate, minimizing the chances of loosening and pull out. And then there is second screw system which gets locked into this, and this screw fixes the plate over the bone, as well as the shaft interlock with the threads of anchor screws, and the head is interlocked with the plate. So the whole thing becomes one unit inside the bone. And the holes are so placed, the plate is slightly manipulated so that the adjacent screw threads is locked with the threads of underneath the screw system. So there are two sets of such holes on the sides of anchor screws. Now let me give you an example. So this is a bone model. You can see over here, this is an anchor screw, and this is the plate which is put over the anchor screws, and screws are put adjacent to the anchor screws so that their threads lock over the anchor screws. These are thread locking screws, right? So this is a CT scan. We have purposely brought the screws out of the bone so that you can look at it, and that is how it looks. So there is a strong set of screw substances which are holding inside the bone, right? Locked with each other. It is so difficult for them to individually get pulled out of the bone. And then we tested it over. So this is the ordinary thread square plate which we usually use with the interlocking screws. And you just see the movement over here, outside the bone of the screw, primarily when is a lot of pulling uh, forces. I will run the video for you. So as I try to bend the bone, taking it away, this is an osteoporotic bone model. You can see the screw have moved. Can you see this? Right? So you can see in this enhanced image very easily. So not only it has moved, this has become divergent. So there's a movement like this, as well as there's a pull outing of the screw threads, and the screw is becoming loosening from the plate itself. This is what happens when you in the osteoporotic bone when there is a pull out strength which goes, and even on the axial screw, once these screw move inside and they make a space, they will tend to come out like that. So if you look at our innovation, this is again a bone model, and you again concentrate on this group of screws. Now, as I try to pull the plate out of the bone, which is a more cancellous area now, there is hardly any movement. Even I am pulling it with a lot of strength. There is no movement of these screws over here because they are interlocked inside each other. I will show you in a broader picture. See this. Just concentrate on this. So there is absolutely no movement of these screws over here. You may be trying to pull the plate out of this, which is possible because it's a bone model, but in this case, it is so much adhered, it is simply not possible to pull the plate out, even in these bone models, right? So that is what the strength is in testing, by mechanically testing the whole thing. So this divergency, this screw backing up is totally controlled when you put up a system like this. And we have done a few pilot testing also. So it is in ordinary fractures, a metaphyseal fracture, diaphyseal fracture, which you commonly see, hardly any space to put up many implants over here, right? And it's a mild uniting fracture. So we did a osteotomy and we did the same thing. So how do we put the implant? Operation steps. So you take the plate. This is a normal plate where adjacent screws will be treated as a thread interlocking screws. So we mark the screws with the help of KYS, all four sides, distally as well as proximally. And then we keep the distance between the two screws between 8 mm to 1 centimeter. So that 6.5 mm screw cancellous screw can act as an anchor screw, which will be dead in center of these two KYS. So we put two wires here and two here also in the proximal. So we can lock both ways. Horizontally also, three screws like this, they can get interlocked, or vertically also like this, where three screws can get interlocked. So in these cases, we have metaphyseal, we are getting bone horizontally more. We can lock it like this, as you can see in this figure. First figure, it is locked. 2K wires are done in two holes. And then finally, we have all placements for anchor screws. This is the center wire which is going. 2K wires, again a center wire we put like this. And then we are putting up the anchor screws over here. One anchor screw and two anchor screw. And over this 2K wires, we will put up the plate, right? So you have anchor wires, now plate is put up, and you have anchor screws which are beneath the plate, and then you put up adjacent screws which get locked inside the with the thread. And when you are putting up, tightening those screws, you can feel the grit of the steel in contact with each other. So you exactly know they are getting locked up or not locked up, right? And even if they don't lock up through the whole length, even if they lock up half of the length, that is also giving additional stability, if not full stabilities. So even partial locking is okay. So you can put up divergently if you are too far away from the holes, or you can converge also if you want to. So at the end, you can see a result. The fracture is nicely compressed, right? And there is a screw, thick anchor screw in between. And these two screws, they are not locking completely, but they are locking partly, but still they are solving the purpose. This is the final figure in the lateral view, and this is in AP view. Whereas this is also completely locked system. And we don't need any additional screws now. This is stable enough for the things to be moved on. And on the table, you can see how nicely it is stable. Once we test it, full range of movement is achieved. and the nothing moves, right? In the X-ray, you can see that it is like very rigid fixation. Hmm? I can show you the X-ray again just to show how rigid it is. There is no movement of any screws. Absolutely rigid fixation just with the help of at two places with a stiff system. So that is what we have tried to innovate. A very strong system, the fifth pillar of stability, as I call it. Till now, orthopedics had only four stability constructs as a primary internal fixation for plate constructs, and that is what we have tried to innovate. And a whole system has been designed. Now it is under development. And to be frankly speaking, I am looking for transfer of technology now with the companies so that a full zig-based system can be developed with special plates and not using a modified plates. And probably we are talking to few companies and it may see the day of light very soon. I was waiting for my patent to come, which had come. And not only this, the whole concept can be tried in different mode and manners also. Uh, with the same thing we have tried in a highly commutative fracture where is hardly any, this is distal fracture, you know how difficult it is to hold it back. Most of the times we will put the platings and then we'll also put up external fixture to support this knee joint. Here we have again used, but from the opposite side. So we have interlocked two, three places, and then we have locked it. So you can use in this concept. So here again, we have done where there is a bilateral, I mean like side sweep injuries type of thing, femur, tibia, ipsilateral fractures are there, and around the knee joints, very unstable fractures. Again, at both the sides, we have interlocked, and we can allow for the early new movements here, uh, where you have put up hardly any bone is there and lot of graftings. You can see fibula have been put up to fill up the defect after compound injuries. And again, we have used the same concept. So a lot of variations can be done. The question of removal, there was a lot of curiosity in us also that will it be easy to remove? Because if the threads are interlocked inside, are they easy to remove? So in our system, where with the adjacent bones, where they are just placed to engage the threads, we tested the removal part also, and you can see it is so easy to remove. So the top screws get easily removed, and then you can remove the plate, and then you can remove the anchor screw as well whenever you want.